So, dear colleagues, it's a great pleasure to join the BUS symposium in 2026. Big thank you to Maxim Bilbenko, who invited me. So this talk will be about wearables in anesthesia and whether they are a gimmick or a game changer. So I do not have any conflict of interest besides the fact that I'm a party member of the working group for big data and digital medicine in our national society. So we are going to talk about what wearables are and what sort of functions of the body can be measured and should be measured with reasonable success. And then we'll talk about the knowledge of the present status and the limitations and the future directions. So importantly to know is that most of us think that, or let's say people think that most of the risk lies within surgery. But actually most people don't die within surgery, but they die within 30 days after surgery. So the risk compared to die after surgery is up to 100 times higher than to die during surgery. So fortunately, our anesthesia care has become very successful and very safe, but we lack still a lot of safety network after surgery. And the two most common reasons for fatalities are myocardial infarction and major bleeding. So this is true for non-cardiac surgery patients. So what are wearables and how can we define them? So wearables are small mobile electronic tools which are transportable and have a wireless communication and can thereby not only measure body signals and body function, but also send them out, and this data can be collected and then be used. But these variables, as I defined them now, they have already been used in the past, as you see here below. So, for instance, already more than 400 years ago, a pedometer to measure the number of passes taken during a day by the wearer, or as you see here in the middle, a visible hearing aid, have been used in the past. And now modern tools like this ring can also be used nowadays. And as you see, a lot of measurable functions can be recorded and be used for measuring patient data. These are two devices, two clocks, common clocks used, arm clocks used by known producers. And you see here a lot of functions which can be measured and then be used for further purpose. Most of these functions are basically part of cardiovascular parameters, but also sleeping power and respiratory function, and also the number of passes taken during a day. So when you look at the number of publications, and this is from November last year, of publications provided and published during the last years, you see here a massive increase of studies, up to 5,000 studies per year for wearable devices. And in the perioperative field, the number of studies is also increasing exponentially, but on a still very low number, as you see here on the bottom right. So 45 publications in 25 based on November the 13th. So on this slide, you see a lot of functions which can be measured. As I said, total steps, passes is one function which is very important. Then general physical activity, blood pressure, heart rate, these are important measurements which are very helpful. Respiratory rate, sleep rate, arrhythmias, for instance, with the detection of atrial fibrillation, body temperature is also interesting, and other functions as you see here. So there's quite a lot of things going on which can be measured. And this picture gives you an overview on when data collection started back in the 1960s with first monitored devices for measuring cardiac function here on the left upper side, and then a lot of further developments over the years. And importantly, one can see different tools on the bottom right green box on how body function can be measured with the detection of light sensors, or the measurement also of chemical compounds through the skin, but also through the exhaled air, through the urine, the saliva, and the ears. So there's a lot of possibilities to measure within the body, and most of all non-invasively, of course. Most of you will know the early warning score, where basically variety of body functions can basically go to the upper or lower limits of the normal, and will then become from green range, which is safe, to yellow, which is not so safe, and to red, where the patient is at risk. And this is true for several different vital functions, as you see here. But of course, nurses or junior doctors are available or required to measure these functions and to detect them over the daytime. And this is not done often. And for instance, in this study by the group of Daniel Sessler and Alpaslan Turan from the Cleveland Clinic, they have assessed how often phases of arterial hypertension or hypoxemia are detected by nurses. And in fact, around 80% of the hypotensive episodes and up to 80% as well of the hypoxemic episodes are not detected during nurses' assessment. So they are missed during the few routine screenings over the 24-hour period when patients are on a normal ward, outside, of course, of the operating theater and outside, of course, of the ICU. And therefore, this is the phase where patients are at severe risk of developing major complications. And when you see here the odds ratio for the risk of, let's say, the risk of complications and from mortality for myocardial infarction or other major events during surgery, but also during the remaining day of surgery or postoperatively between the days 1 and 4, you see that intraoperatively, this is here, and also on the day of surgery, this is here, the odds ratio is very low and not very much increased for 10 minutes increases in hypertension. But when you look on the day 1 to 4 postoperatively, which is here on the bottom, the risk is far higher, the odds ratio is far higher for hypotension versus non-hypotension, developing into a 30-day increase in mortality in patients after non-cardiac surgery. And similarly here, when you compare the intraoperative hypertension compared to the postoperative hypertension, you see also here on the bottom right, which is basically this side here, that the risks for different major complications like myocardial let's say injury, or stroke or myocardial or other myocardial injuries, of course, as you see here, and death, they are far more higher increased than when they happen intraoperatively. So again, patients are at much higher risk if they develop problems in the postoperative period compared to the intraoperative period. And as I said, during the department stay on the normal ward, these events are often not detected and put the patient at high risk. So this is from a review from last year, from 25. So when you look at studies who basically assess whether these detections of negatively changed vital signs lead to any good outcome, then the studies show that patients who use these devices, they have a lower length of hospital stay, they have less postoperative complications, the risk of mortality is lower when the vital signs are measured continuously on the normal ward. Again, this is a recollection of different studies where you can see what sensors have been used to measure what sort of features, and as you see here, there are several features which can be measured, and here on the outcome benefits, you see that several positive effects have been detected. This is also from another review, which is quite interesting. Basically, they collected data on the percentage of patients here on the y-axis and vital signs which are deranged to the lower or to the higher range of the normal. And you see that quite often in 18% of the patients, vital signs have been too high with respect of the heart rate, or the saturation has been too low in 20% of the patients, while the ventilatory frequency, the VF, has been too high or too low, and the blood pressure has been too low, also in almost 25% of the patients. So these are the patients that you will also expect in your department. And again, when you have wearables, you may detect these changes in vital signs outcomes. Otherwise, you won't not detect them, of course, if you don't use the devices. This is, excuse me. So this is basically a recapitulation of features, characteristics which wearables should have when they're used on patients. So to put all this together, devices which are used should be small, easy to use, they should have few artifacts, and they should allow for continuous measurement. This is how a device could look, at least in one setting, of the author of this article, of this review article from the BGA, which is also recent from this year. So as you see, there are several features, several sensors, several different parameters which can be measured. But of course, the question is if this has really to be so complicated, or if you can only rely on a watch-like item or a ring, for instance. And if this is basically thought through, then you see here basically the patient who wears this device. The data goes into a cloud. Then you see this data on a remote screen. It goes into the medical records, of course, and it goes into a cloud. And there is, of course, also a possibility to analyze this data outside of the hospital after the firewall and with anonymized data. And there, of course, this data can then be used for further research. So The question is, how reliable are these devices? So when you go to a step count, these devices are pretty adequate. When you go down then to heart rate devices, the accuracy is also quite good. But for instance, if you clap your hand, or if you use walkers or canes for patients who step, then you may get some artifacts. The respiratory rate and also the blood pressure are not so reliable and accurately measured, and the artifact risk is much higher. So, but as you know, these devices are quickly developed and improved, so the accuracy is increasing, but it's not perfect. The temperature is also not so stable. Continuous blood pressure measurement has also some benefits and is stable to some extent, but in older and hypertensive patients, it may still have some problems, as some data show. Interestingly, atrial fibrillation detection is very well done now with some smartwatches. Again, if people move more than if they move less, then their stay of hospital length is decreased. So the readmission rate is lower and the postoperative complication is lower. So knowing how well a patient is able to move again after surgery has some positive implications. There are some obstacles to the fast improvement or enrollment of this technique in the hospital setting. Basically, it is expensive. Often there are too many alarms, which is called then basically is fatiguing the team. This is called alarm fatigue. There are false positive alarms. There's technical issues with batteries and Wi-Fi also. And elderly do not often use devices so well and do not like them so much. But some studies show that patients are satisfied when they use these devices, and the compliance has been reported to be quite good. So there are some potential cost savings, but this has to be thought through, as you see here in this slide. But it really depends on what sort of contract you get and how costly your healthcare system is. Limitations of the wearable devices is that there are few high-quality studies for the moment. The cost-benefit discussion is, of course, very important. Alarm fatigue is a major issue. If you think that there are up to 15 alarms going off per bed per hour on the ICU, of course, that's not so often on the medical ward, but still there are very many alarms which can go off. So you have to set the normal correct threshold and use these devices properly. Future directions. The technique is booming. Of course, you need some training for patients and for healthcare staff. And if you have trained nursing, then this will reduce the burden of false alarms. And machine learning, artificial intelligence can help a lot probably with these devices. So there's no question that these devices may have a field, they may be used as a modern early warning systems, as I showed you before. So the potential is that these devices may be used here, as I said, as a watch on the mobile, not in constant contact with the Wi-Fi system. This is the left side here of this graph. So this will save on energy. While if you use this device with contacting continuously the Wi-Fi system, this may use much more battery and will also be much more expensive to some extent. So the new device is basically not in constant contact with the Wi-Fi system. There's AI already included in this watch. here in this watch, as you see, and only occasionally this device will connect to the Wi-Fi. So this slide shows how this technology is included more and more in our medicine field. Wearable devices augmented with AI are a strong new technique approaching our clinical field. They will be monitored, they will be used to measure the development of our patients. We can personalize the treatment. There are some legal challenges like data use and data privacy, and especially if you share this data. New modern tools with 5G will of course improve also the sharing of this data. In conclusions, perioperative wearables are potentially very valuable devices. Some early data show some benefits, and there are some barriers to wearables, but they can be overcome. And we need more interventional randomized trials. So coming back to my original questions, are wearables in anesthesia a gimmick or a game changer? I would say that currently they are still be considered as gimmicks in most departments. We are trying to understand what we can do with them, but in the future they will certainly be a game changer and can help to reduce the burden of our intensive care units and still keep the patients safe on the normal wards. So I hope you like this presentation as a sort of my eye opener and a mind blower. And if you have any questions, I'm very happy to reply and to respond them. And you may of course also use this presentation for further guidance. Thank you very much.